Hello, hello everybody. Welcome to the webinar, which is a joint webinar between the British Pharmacological Society, UK Pharmacogenomics Stratified Medicine Network, and the Association of Physicians of Great Britain and Ireland. My name is Munir Mohammed. I'm going to be chairing this session. I was president of the Association of Physicians and of the British Pharmacological Society, and it's great to bring the two organizations together to be able to undertake this webinar. This is very much focusing on getting the NHS ready for pharmacogenomics. The Association of Physicians was formed in 1908 by Sir William Osler. And William Osler says that variability is the law of life. No two faces are the same, no two diseases are the same. And in fact, he didn't have many medicines at that time, but the same thing happens with medicines as well. There's lots of variability in medicines, as you'll hear, and what are we doing about that? So the format for today is that I will start off a presentation for about 20 minutes, and then I'll hand over to Vicky Chaplin from NHS England, and then from Adrian Lorena from Spain, who's going to tell you what's been happening in Spain. So we'll get a flavor of what's happening in the UK, in England at least, and then in Spain, and compare and contrast the two. And after that, we're going to have a panel session, which I'll share with our two speakers, but it'd be great for you to be able to ask questions. So if you want to ask questions, then please use the question and answers icon at the bottom of your screen. And if you write your questions in there, I'll be able to read them out and ask the panelists. I will also be able to answer that as well. So we've got 93 people online right now, but we have had over 300 registrations. Some people will be joining a bit later. However, there will be people who will be watching this after it's finished as well. So Adrian, if you can just turn off your camera, if that's okay, then if you can come back in once it's time for. Thanks very much. That's great. Okay, so I've nearly forgotten. I just want to acknowledge the sponsor, Ananda Developments, for the support of the meeting as well. So thank you very much. So I will go straight into my talk and then hand over to Vicky Chaplin. So let me just share my screen if I can. Okay, somebody from BPS, let me know that you're seeing full screen, please.
We can see presenter view at the minute, Munir.
Okay, sorry. I've got two screens. Okay, I should be full screen now.
Yes, perfect.
Great. Okay, well, thanks very much, everybody. What I want to do is to present to you the report which is published between the Royal College of Physicians and British Pharmacological Society and give you some context in terms of what's been happening, what happened before then, as well as what's happening since then as well. And Vicky will then tell you about exactly what the NHS is doing at the moment. So there is a huge amount of variability in the way people respond. At the moment, the way we treat patients is the basis of one drug fits all, one dose fits all. And if you look at the variability that occurs in the way people respond to medicines, that can affect efficacy as well as safety. And there are many factors that can determine this variability. There is the food interactions, demographic factors, etc., but also genomic variation as well. So if you take data in the literature as to the degree of variability, you find that more than 90% of drugs only work in about 30 to 50% of people. So for some drugs, you have to try them for 3 months to see whether they worked. And if they haven't worked, you go into the second drug. If that doesn't work, you go into the third drug, etc., which is not good for the patient. It's not good for the health economy, etc. On the other side is the safety. Many patients develop adverse drug reactions, unfortunately. Work that we've undertaken has shown that adverse drug reactions account for 6.5% of all adult hospital admissions. At this very moment in time, there are 10 800-bed hospitals in the UK occupied by patients with adverse drug reactions. That's 8,000 beds. That's a huge number of beds. So pharmacogenomics is one way to be able to reduce these problems with both efficacy and safety. So what is pharmacogenomics? Well, pharmacogenomics or pharmacogenetics, at least a term, was first of all coined by Friedrich Vogel, who's on screen, is a German pharmacologist, in 1959. And then in 1997, Marshall, who's a Nature of Biotechnology, coined the term pharmacogenomics, which is a broader term to be able to take into account the whole of the genome. And the definition that's on the slide at the moment is a definition that I use, which is really to be able to highlight that pharmacogenomics is important for discovery of drugs and development of novel drugs, but we're not going to be talking about that today. But what we're going to be talking about today is really optimization of the drug dose and choice in individual patients to maximize efficacy and minimize toxicity. So the next question is pharmacogenomics really important? Will it really affect me? Will it affect my patients? Will it affect my family? Well, pharmacogenomic variation is very common. 99.5% of the population have at least one polymorphism in a pharmacogene. 25% of you who are watching this will have about 4 pharmacogenetic polymorphisms. And clearly, polymorphism frequencies vary with ethnicity. So although most of the studies have been done in European ancestry populations, it is important that as we move forward, we understand the diversity in genetic variation so that we make sure that we're not exacerbating health inequalities in different ethnic groups. So pharmacogenomic variation is common. Then you might ask the second question, well, am I going to be exposed to drugs where there is some pharmacogenomic guidance? Yes, that is also true. There are 517 gene-drug associations recognized by the FDA at the moment. And work which has been undertaken in the UK by Emma Baker has shown that over 1 year, 58% of the population will be prescribed a drug affected by pharmacogenetic polymorphisms. And work which we've undertaken, which is not published yet, has shown that in a polypharmacy cohort, there will be on a median of 2 drugs that require pharmacogenomic optimization, but in some people, it can be as high as 6 drugs. And given that polypharmacy is increasing, I frequently see patients in my practice on 10, 15 drugs and so on. And it can be quite difficult to be able to reduce the numbers of drugs people are taking. And in the future, something that we're looking at is see whether you can use pharmacogenetics as part of the medicines optimization and deprescribing. So let me give you one example to start off with. And this is perhaps the poster child. This is with a drug called abacavir, used in HIV in association with other antiretrovirals, maybe less used nowadays because of newer antiretrovirals. But when it was first licensed, it was shown to cause severe hypersensitivity reactions, which were characterized by rash, gastrointestinal manifestations, and in patients who were rechallenged, if they've already had hypersensitivity, they got a much more severe reaction, and some patients died from those hypersensitivity reactions. So work which was undertaken by Simon Malal in Australia, and then Seth Hetherington in the United States, and then by ourselves in Northwest England, was able to show a very strong association with HLA B star 5701. This is an HLA allele on chromosome 6, and this association was so strong that it was felt that we should be implementing this into clinical practice. So we also asked the question, would it be cost effective for the NHS to be able to introduce this for the NHS? And our cost effective analysis showed that this would be cost effective, and in some cases it might be cost dominant depending on what the other drug the patients would go on if they couldn't go on abacavir. So these data were used by HIV clinics in the UK. We published this in 2004. By 2006, every HIV clinic was using genotyping for HLA-B57.1 before patients went on to abacavir. And the net effect of that has been dramatic. The incidence has decreased from 5% to less than 1%, highlighting the utility of pharmacogenomics. And since then, there's been a lot of work going on, work with the NHS, and we before the pandemic, we held a workshop with Sue Hill and with Mark Caulfield and various other people, and highlighted the potential opportunities and challenges. I won't go through this slide, but there's a lot of different aspects in there in terms of what is needed to implement pharmacogenetics, and what are the challenges of those particular aspects, and the mitigation that will be required to overcome some of those challenges. And hopefully Vicky will be highlighting some of those challenges. And clearly it has been government policy as well that we should be thinking about implementing pharmacogenomics. Genome UK, The Future of Healthcare, which was published a couple of years ago from the previous government, but the current government, I'm sure, would agree with this as well, is that there is a need to be able to implement pharmacogenomics for our population. Now, we know that there are many drug gene pairs which have been identified, which can affect patient outcomes, and those drug gene pairs have been replicated. At the moment, only a few pharmacogenetic tests are available in the NHS, and we know that there are guidelines produced by international groups such as the CPIC, which is a Clinical Pharmacogenetics Implementation Consortium, as well as the Dutch Pharmacogenetics Working Group. And in the United States, there are some sentinel sites which are already implementing pharmacogenomics, and you'll hear from Adrian later on about what Spain is intending to do in terms of implementing pharmacogenetics. With all the information and all the evidence that's been gathered, we formed a working party. I see there are some raised hands. I don't know whether BPS team can deal with those. I'm not sure what those raised hands, it may be technical problems. Please put some, if you put comments into the chat, the BPS team will be able to look at those and get back to you if that's okay. So working with the Royal College of Physicians and the British Pharmacological Society, I chaired a working party to look at pharmacogenetics. This not only included medical specialties represented by the Royal College of Physicians. So the Royal College of Physicians represents 26 medical specialties, but we also invited general practitioners, anesthetists, psychiatrists, and also pediatricians to the working party. And we also had the Royal Pharmaceutical Society working with us on this. And the working party looked at the evidence, and this was very much a four-nation approach. What we were trying to do was not just for England, etc., but a four-nation approach, including Scotland, Northern Ireland, and Wales. But we also feel some of the things which are mentioned in the report are not only relevant for the NHS in the UK, but also for other countries as well, because there's some general principles there which apply to other countries as well. And these are the recommendations that we came up with in the report. The first is that it was now time to implement pharmacogenetics in the NHS. This needs to be implemented in all sectors, primary, secondary care, and it should be centrally funded. We don't want particular trusts to be able to think, yes, I've got the funding to be able to do, other trusts don't. It will just lead to a postcode lottery. And so central funding is important, not to exacerbate health inequalities. There are many changes which are occurring all the time in the pharmacogenomics field, and we need to make sure our testing strategy is agile and is up to date to benefit our patients to the greatest degree. Unfortunately, one of the major challenges will be the education training of our workforce. We need to upskill our workforce in pharmacogenomics, and we therefore need a comprehensive education and training strategy as part of this. But even when you do have a trained workforce in this, nobody will be able to remember all the different drug gene pairs and what how to interpret those and what action to take. So therefore, it is going to be important that we have good decision support systems, intelligent decision support systems that really help in making that decision and make sure that we're not disrupting the clinical pathway too much. And clearly, there is a need to do further research, and there's a lot of discovery work going on, and that discovery work will eventually be implemented into new drug gene pairs for our population. And most importantly of all, there's a need for clear lines of communication with the patient public, and I'll come back to that. So here's one example of drug gene pair that we highlighted in the report. That is with fluoropyrimidines. The fluoropyrimidines are used in about 15% of cancers. Unfortunately, they cause severe toxicity in about 10 to 40 in some patients, and in 10 to 40% of patients. This can lead to myelosuppression, diarrhea, and fatalities in about 1% of patients. In most cases, this is due to dihydropyrimidine dehydrogenase deficiency, which is polymorphically expressed. And there was so much evidence associated with this that the regulatory agencies, the European Medicines Agency and MHRA, looked at this and changed the label. And in October 2020, the NHS, not only in England, but also in the other developed nations, introduced pharmacogenetic testing. In England now, we do about 38,000 tests per year. So we've gone basically from almost 0 to 38,000 tests, and which is a fantastic thing that's happened. Obviously, these 4 variants that we test for at the moment were derived from European ancestry populations, and work we've undertaken suggests that we need to think about other variants as well to be able to introduce the panel. For example, in the African ancestry population, a variant which occurs in 2% of the African population is this particular variant, C557A. And again, that's something that we may need to consider in terms of implementing for the future panel in the NHS. Interestingly, a systematic review and meta-analysis has just been published this week in BMC Cancer and shows the carriage of one or more of these 4 DPYD variants is highly correlated with mortality, with an odds ratio of 34.86. That's a huge odds ratio, highlighting the importance of actually implementing this for our population. So in the report that we published, we talked about multidisciplinary working. And the report is directed towards medical and non-medical prescribers. We have a lot of non-medical prescribers, and they also need to be upskilled in pharmacogenetics. And clearly, if you look at where prescribing occurs, most of it occurs in primary care. So it is important we focus on primary care as well as on secondary care, where most of the newer drugs are used. Clinical pharmacists are going to be hugely important in implementing this within the NHS. But obviously, in each particular specialty, the individual specialists will have to have the specialist knowledge of pharmacogenomics in their specialty. Clinical pharmacologists can also act as champions in this area from a medical perspective. And there will need to be some multidisciplinary team approaches where complex cases will need to be discussed in order to be able to make sure the pharmacogenetics is being used properly, looking towards the future. And as I said, decision support systems are going to be important. Now, there is this thing about consent, and when you say it's a genetic test, do we need to take consent? We feel that this is just verbal consent, as you would take if you're going to take a blood sample for urea electrolytes or full blood count. Ask the patient whether they're happy to have that, and that's all it would be. And explain to the patient the need for the pharmacogenomic test and what you will do with the results. And most prescribers should be competent to be able to undertake that verbal consent from pharmacogenetic testing. We're not asking for it. We didn't say there would need to be any written consent, and there certainly does not need to be any genetic counseling. We feel that a pharmacogenetic test should be viewed as the equivalent to renal or liver function testing to guide prescribing decisions. It is just information. There's nothing special about this. When I prescribe, I look at people's renal function testing, what other drugs they're taking. When I have the pharmacogenomic information, it will just be more information that allows me to be able to guide my prescribing decisions. Obviously, if you're going to take a whole genome sequencing approach in your particular patients, then there will be other genes which are important in terms of familial inheritance, etc., disease predisposition, and therefore, in that case, different types of consent procedures will not be taken. But in most cases, pharmacogenetics, there's be panel type approaches, and one doesn't need to undertake that kind of written consent. Now, genotyping can be done by very many different ways, single gene drug pairs, and multiple genes. The report suggested that we needed to go to a panel of pharmacogenes, that is, that you do the test when it is required because of a particular indication, but you do a panel approach whereby you have a large number of genes that you can store on the electronic health record for future use. So they preempt future prescribing. Obviously, many people do have whole genome sequencing being undertaken at the NHS as well, and we should be able to extract pharmacogenomic information from that. In some cases, we may need to use point-of-care testing. For example, with aminoglycosides, Vicky will talk about that, clopidogrel as well. One of the things we need to think about is that GLHs remain the main platform undertaking genetic testing, but the model for whole country implementation will need to ensure there's enough laboratory capacity. Now, when we published our report and recommended panel testing, we didn't have evidence of the utility of panel testing, but since then, the PREPARE study was published, which is in the Lancet last year, which is a 12 where we used a 12-gene pharmacogenetic panel. It was in 7 different countries in Europe, including in the UK, where Liverpool was the center. And in this particular open label, multi-center controlled cluster randomized crossover implementation study, we were able to show that clinically relevant adverse drug reactions were reduced in those people who had pharmacogenetic testing compared to standard of care, leading to 30% reduction in adverse drug reactions, which is a fantastic result from a single intervention. Now, education and training, as I said, is going to be important. It will need to start at pre-registration for medical, nursing, pharmacy professionals, so that we actually need to embed that into curricula. In post-registration, people may want to take specific courses in order to increase their knowledge and skills in pharmacogenetics. But the majority of people will need to know about something about pharmacogenetics, not necessarily be experts, and we will need just-in-time information for those individuals as well. So a multimodal way of being able to undertake education training. And there's lots going on, hopefully more so going on in the future, in the near future. And as I said, patients and public are important. We need to make sure that they understand the benefits as well as the limitations of pharmacogenetics. And in our report, we included patients in our working group as well. And this is a quote from somebody who suffered from Stevens-Johnson syndrome, toxic epilepticrosis with carbapenem, been highlighting that doing a genetic test which could have saved her from having STSTN would be extremely important. Jane spent about 4 weeks in hospital, a lot of the time on so specialist unit, trying to overcome the toxic epidermal necrosis that she suffered from her carbamazepine therapy. So I'm just going to finish off by highlighting this quote from Nyrin Bevan, who founded the NHS on the 5th of July 1948. And he said the underlying principle of the NHS is to provide care at the point of need from cradle to grave. And pharmacogenetics certainly fits in with that. The current government has aim to move towards more prevention, and pharmacogenetics, by preventing either lack of efficacy or preventing adverse drug reactions, certainly fits in with that strategy. So let me just finish off by thanking all the people who were involved in writing and working with us on this particular report. The report is dedicated to the memory of Professor Donald O'Donoghue, who was Registrar of the Royal College of Physicians at that time. Unfortunately, Donald died because of COVID in the middle of the report, and so on. So we dedicated the report to him. Emma McGovern, Richard Turner drafted the first draft of the report, and all the other members that you can see on the slide there helped in developing the report. So thank you very much for your attention. I will stop sharing and I will move on to Vicky. Vicky Chaplin, please. Can I get you to do your talk, please?
Thank you, Munir. Okay, good evening, everyone. It's lovely to see so many people on this webinar. I'm Vicky Chaplin. I'm the Senior Clinical Lead in the Genomics unit at NHS England. And so, as Munir has said, I'm going to talk about the implementation of pharmacogenomics in the NHS, particularly in England. Next slide, please. So just as a kind of an overview in terms of what's coming, I'm going to talk a bit about what the NHS Genomic Medicine Service is, which hopefully lots of people are quite familiar with, but if not, to give you kind of the background of what we're working with, what the National Genomic Test Directory is within that, and then talk a little bit about where we are at the moment with current pharmacogenomic test availability. And then kind of moving on now in terms of how we are implementing pharmacogenomics as a priority, give you a bit of information and insight into our pharmacogenomics and MedZoc network of excellence, and then kind of look to the future and think about where we are, where we're going and where we're heading with what we like to call genomics informed medicines optimization. Okay, next slide, please. So for those who aren't familiar, the NHS Genomic Medicine Service was launched in 2018 by NHS England. So following on from the 100,000 Genome Project, it was, this is a nationally commissioned service. So thinking again about in terms of kind of access, genetic testing is a specialised commissioning service that is kind of from a national level. So when we make decisions about it, it's available for everybody in the country, and it offers access to genomic testing for all patients and public in the NHS in England. In terms of our setup, we divide ourselves into 7 regions, which centre around our genomic laboratory hubs, who we commission to deliver the testing for our patients. And they are supported in turn by what we call Genomic Medicine Service Alliances, who give us that kind of multi-professional clinical approach to support implementation into practice, which of course is key. We also have our specialist clinical genomics services, and we work in conjunction with a number of partners. So Genomics England, who many people may have heard of, who supply our whole genome sequencing, and we work with them on various other things. We now have cellular pathology genomics centres, and we also work very closely and we have the NHS Genomics Education Programme. So they were previously in Health Education England. We have now merged, so they're also in NHS England, and they kind of work side by side with us to make sure we have that workforce training and education available. Next slide, please. So this, I guess, is kind of the backbone if you want to know what the Genomic Medicine Service delivers. It's all centred around the National Genomic Test Directory. In typical NHS fashion, it's an Excel spreadsheet at the moment, but we are working on digitising that. And essentially, I suppose for ease, we have split it up into 2, and you'll see on the left-hand side there, it says that there's a test directory for rare and inherited disease and a test directory for cancer. I imagine lots of people on this webinar are familiar. I suppose if you were to think about it another way, is kind of our germline testing and our somatic testing. But essentially, it's one test directory. Now, historically, we had working groups, expert working groups, who evaluated the tests. We still do so for the tests that go on the test directory. Historically, we had rare and inherited disease and cancer-focused ones. And then I'm really pleased that over the last kind of 18 months, 2 years, we now have a functioning pharmacogenomics test evaluation working group, which is really important because essentially with the genomic test directory, anybody can apply. So from clinicians, industry, patients and members of the public, if there is a genetic test that it's felt should be commissioned nationally, you can make an application to the test directory. We have an annual cycle, and those applications are reviewed by our expert working groups. And so now, as we're seeing this kind of increase in interest and usage of pharmacogenomics, we have that pharmacogenomics group there to advise us and recommend to us essentially in NHSE what should be commissioned. Next slide, please. And I just wanted to give you this as a bit of example. So in terms of, and this is kind of set the scene for where we're going with the rest of the talk, it's having the test is extremely important, obviously, but we're also very aware there's lots of things that sit around it. And I think a really good example of that is a test that we call R65. That's the number in the test directory. But it's a test for mitochondrial RNR1 for an increased risk of aminoglycoside-induced hearing loss. And it's in the test directory for patients that are likely to have recurrent and long courses of aminoglycoside antibiotics. So an alternative can be considered. So patients with conditions like cystic fibrosis, for example. Now, there is an MHRA drug safety update that was released a few years ago. Potentially, there's quite a few patients that could benefit from this test. And it's interesting because this test actually predates the Genomic Medicine Service. It has been around longer than then. But when we looked into it, there wasn't actually as much usage of it as we thought. And I think, really there's something here about how we kind of work together across the healthcare service to make sure that awareness is there, the education and training is there, and that people are kind of confident to use this. So, these are some of the examples, and you'll see these themes running throughout. We spoke to the BNF, and you'll now see that our British National Formulary, it actually references in notes for prescribers the fact that there is a genomic test directory, so that genetic testing is something to consider when thinking about medicines. And next to the monograph for aminoglycosides, it does reference the fact that this test is available. There was also some wider questions around implementation. So we worked with the specialist pharmacy service, who provide a lot of medicines information to the NHS in England, and with the expert group who were working on this, so a combination of people in genetics and also in aminoglycosides and antibiotics, we put together this article which gives a bit of further information and support. And then also importantly, information for patients. So a few of our pharmacy leads worked with the Cystic Fibrosis Trust to make sure that this patient leaflet was available to explain, when this test is being given, what does it mean, and what does the result mean? Next slide, please. So that's some examples of kind of some of the work that we've done, but I really want to focus on where we're going. And I think that was really kind of set out, and you'll see quite a lot of information in there about pharmacogenomics in our genomic strategy that was published in October 2022. And you'll see within that, particularly in priority 2, we really made a commitment in terms of enabling both precision medicine, which obviously we see quite a lot, but also kind of wider pharmacogenomics, reducing adverse drug reactions, and kind of optimizing our more commonly used medicines. And we set a number of commitments out in there in terms of that work. And I think we'll see as we go through the presentation kind of how we are starting to address those. Next slide, please. So this is just a quick summary before I go on. So just to give us a bit of a recap in terms of where we are. So as I mentioned, in terms of existing testing, I've talked a little bit about the mitochondrial RNR1, and we have some other tests on the test directory. So DPYD, which Munir's already talked about, which has been kind of really successful. It has a clinical policy statement as well, and the uptake of that has been really, really great. We also have TPMT and NUD-T15, specifically for patients in ALL. But that is available on the test directory. And underpinning that, we have something called Genotes. So I mentioned that we work with National Genomics Education. They provide education and training support. And I'll show you a screenshot later. It's just a really good in the clinic resource. In terms of where we're going, in terms of development, we are now also thinking about what other technologies are. Munir's also alluded to the fact that, we're seeing point of care tests as well. And I think we have to be aware of that. We don't personally commission at the moment point of care tests from NHS England in terms of the Genomic Medicine Service. But you'll see when we talk about our network of excellence, we are exploring kind of the work that's happening with those and how they're being used, because to understand, all the different ways that pharmacogenomic testing can be delivered. We're needing to think about how we develop our infrastructure, because the key thing here, although pharmacogenomic testing is very much genetic testing, it's actually quite different in terms of delivery of the testing. So we really have to think about kind of high scale, kind of more low complexity, high volume testing. And we have to think about the infrastructure we need to deliver that. And that involves also exploring various testing solutions. So, thinking about panel testing versus single gene testing, what we can use in terms of whole genome sequencing, and also where this is delivered. So where is the best, most convenient place for the patient? And you'll see when I talk about progress in a bit, that's in primary care. It's not, one thing to take it out of our specialist genomic services, but then it's actually medicines are everywhere. And where does that test need to be to really best inform the prescribing and the use of medicines for our patients? And then you'll see on the right there, a lot of this, as I've said, is being informed by a network of excellence. But I'll just go to the next slide because we'll talk a little bit about that later on. And so this is a nice graph, I suppose, just so you can see where we're going. So I think this is kind of our vision in terms of where we see genetic testing going, as in we see it increasing significantly. And you can see over the next few years, we can really see that strategic shift to embedding pharmacogenomics into common diseases. Next slide, please. So I kind of touched upon it a bit with mitochondrial RNR1, and I just want to talk a bit about all the things that we are thinking about in terms of implementing of pharmacogenomics. And I think it's really nicely summarized by the diagram on the right-hand side. So as I've said, we call it kind of, linking genomics and MedSop. And we need to have the tests available, absolutely. But all of the stuff that underpins it to really embed this into and integrate it into our clinical workflows and pathways to make it convenient and effective and efficient for our patients. And so there's various things that we think about. Workforce development is huge, and we do have great pharmacy leadership in this area, but obviously pharmacogenomics is everyone who touches medicines. It's multidisciplinary, so we're really starting to think about what resources need to be out there for everybody. Horizon scanning in terms of what's coming, because that's so important at the moment. Like as I've showed you, we don't have loads and loads of pharmacogenomic tests out there, but when they do come, we need to make sure that we have that infrastructure in place, think about where they're going and what we need to know. I've talked to you about a test evaluation and implementation process, all the things we consider. And also this is a constantly evolving space. So it's really important. And I think that, the genomic space is really good for that in terms of showing how, really linking kind of research and innovation very, very closely to translation into practice. So we can, constantly make sure that our patients have access to the best innovations and the interventions with the most up-to-date evidence. So integration into clinical workflows and pathways I've touched upon, and another bit which I'll talk about in a bit more detail, which we think really underpins it, and anyone who has read our genomic strategy will have seen that, is we do feel quite strongly that in terms of the delivery of pharmacogenomics, anyone who's used to kind of prescribing or using medicines, we have quite a good structure in the NHS in terms of clinical decision support and flow of information in terms of kind of summary care record, etc. And essentially, if we're thinking about the medicines data of the patient, then that pharmacogenomic data needs to go with them too. So in terms of thinking about that digital infrastructure that we need and interoperability, that's a big part of the work we're doing. And then really importantly, raising awareness and engagement. And then all of this is supported we have a Genomics Informed Medicines Optimisation Board, if we just go to the next slide, and that's chaired by Sue Hill, who is our Chief Scientific Officer for NHS England and also the SRO for Genomics, and David Webb, who's the Chief Pharmaceutical Officer, which I hope really clearly shows that this is a really linked national priority in terms of genomics informing the use of medicines. In that group, we have, a real mixture of expertise from across different parts of the NHS. So we can really think not just genomics experts, but experts in terms of medicines use and how we implement these. So we can really think about how does this actually work in practice and how do we take these forward. And on the right-hand side there, you can see they are kind of our overarching programme aims. Next slide, please. And then this is just another example. There's lots of words on here, so I won't go into loads of detail. But again, really thinking about how we embed genomics informed medicines optimization, again, into our existing structures. We don't want to create this kind of separate industry of, over here, you go here for your pharmacogenomics. This needs to fit into our day-to-day pathways where medicines are used and reviewed and prescribed, and we need to think about how best we can support the integration of genomics into those. So that's really about working from a national level, making sure those priorities are linked, at a regional level, we've got really great leadership through our genomics regions, but also linking into our regional kind of MedSop structures as well. And then trying to just reach as many kind of champions and people who are interested in genomics now to really try and think about upskilling and supporting these services as they grow and develop. Next slide, please. And also, just we make sure that we have to talk across the system as well. We have responsibility from a national level. So I've touched upon the fact, you know, we've worked with the BNF, and they now refer to genetic testing in there. Thinking about places like the specialist pharmacy service that provide medicines information, thinking about how we can get genomics information into there. We have various teams in NHS England. Obviously, we're not just genomics. And again, if we want to integrate into certain clinical pathways, we need to work with those teams across our organisation. Think about the service that is being commissioned and how testing may fit in. We're also working with NICE in terms of, I've mentioned our evaluation process. They have an evaluation process, and we've really been talking about how can we make it clear in terms of where you go to have a test evaluated and how these things come into the system. And obviously working with MHRA in terms of kind of the regulation of some of these medicines and associated tests, and DHSC. Next slide, please. And I've already mentioned GeneNotes. So this is just so you're aware that these education resources are available. They're freely available, and you can log on and have a look. And essentially GeneNotes, so you can see the abbreviation there, Genomic Notes for Clinicians. So you can go on and see information about certain genetic tests, and you know, it gives you a bit more background, some things to consider if you are working with a patient who has just had one of those tests. Next slide. And you'll see that there is a specific pharmacogenomics section now, which is great. Next slide. Okay, so what I wanted to really finish on today is in terms of where we're going. So I've talked about kind of all the things that are underpinning it. You know, Munir's mentioned in terms of the personalised prescribing report, where we think we go. Obviously, there's all these things we have to consider in terms of how do we commission it? What's the best way to commission it and put these things into the NHS? And across the entirety of the genomic medicine service. Last year now, I think, yes, my time has gone off, but yeah, it would be last year, that we established what we call NHS Genomic Networks of Excellence. And these networks of excellence are built up of our colleagues across the genomic medicine space in certain areas of expertise, so they can really focus in and drill down, working with partners in industry, academia, research, and really think about what does implementation into the NHS look like, have specific projects, and then feed that information back to us to inform our commissioning decisions as we continue to develop these services. So you'll see we specifically have a pharmacogenomics and medicines optimization network of excellence. Next slide, please. And this is an overview of the original work packages that were signed off for 2 years when the Network of Excellence started. I'll talk a bit more about progress in a second, but it's also thinking about, you know, a number of questions that we need to answer. Thinking about patient views in terms of designing the service. Community pharmacy, how does pharmacogenomics go into there? So obviously we're thinking about, you know, in terms of certain NHS pathways, but, you know, that also may be a very convenient great place for the patient to access these tests. Adverse reactions with cancer, pharmacogenomics in mental health. Palo is thinking about that point of care testing again, and pharmacogenomics in clopidogrel, which I will touch upon. And there are more work packages that are being looked at, considered, and signed off. Next slide, please. I just really want to give a quick overview of progress, which I guess gives you a bit of an indication. So this is well, actually, probably not all, some of the lovely people involved in this project. And if we go to the next slide, just if you haven't heard of it before, so Progress is a trial that's running out of the Northwest. If you just click a few more times, Becky, there's a few things that will pop up on this slide. So, you know, this project is really thinking, it's looking at panel testing, the implementation of panel testing in primary care for certain drug gene pairs. And it's really kind of considering from genotype to phenotype, the technological solution we need in the middle, and then overall implementation. And all around that, wrapping around that, thinking about patient and public attitudes, our approaches, and, you know, what is the most cost-effective way? How can we, you know, use the benefits of the data potentially? How can, you know, in terms of reuse of results for patients, etc., etc. Next slide, please. And just keep clicking. Sorry, I think these are. So just so you have an idea, so patients can be enrolled in this at the prescription of a new medicine, which at the moment is an antidepressant, a statin, a PPI, or an opiate. If you click again, please. And that information, so their test will be sent off to the lab, and the result will come back so they can have a discussion with their clinician about pharmacogenomic guided prescribing. Just keep clicking to the next slide. And at the moment, that's okay. So there's about 250 patients that have been enrolled so far. Turnaround is in about a week, and we've seen a 30% change in prescriptions for patients who have been enrolled in this. We're now looking at phase 2. So it's now being rolled out from the Northwest, which is where it originally started, into sites across the country. So we have that national coverage now, as well as thinking about integrating with other providers. So if we go to the next slide, the technological part is a really important part of it. And it's about thinking, as I mentioned before, how can we make sure that pharmacogenetic data is available alongside when you're thinking about the medicine, and also in a clinically relevant format and clinically relevant time frame. You just click a few more times. So the team in the Northwest have been working with, you know, you'll see on the right there, providers that you're very familiar with, like Epic and EMIS and System 1, and using something called the Progress RX system to kind of give that advice back from the test. And we're aligning this with, you know, commonly used data standards in the NHS, because obviously we want to be able to interoperate across the system. Next slide. And then this is just kind of the last slide on that. So basically, you know, as I mentioned, it needs to be interoperable. We need a standards-based approach. So really thinking, one more click, please, that we need a single source of guidance within the NHS in one place, not just the genomic data, but also thinking about the guidance that relates to it. We do also need, and this is the one things that is being thought about much more broadly across the pharmacogenomic community, you know, what is a kind of human readable format we can have so everyone can access it. I suppose a good example to compare it to is, for example, everyone knows about like the renal drug handbook if you're treating a patient, and we know that there's existing guidance such as CPIC and from the Dutch group, but we need consensus and uniformity for us here in the UK, and that's really important. Next slide, please. So just to finish off, you will also be aware that NICE have released some diagnostic guidance for CYP2C19 genotype testing to guide clopidogrel use after ischemic stroke or TIA. And if you are BDI'd, you may have noticed that on that page as well, NICE have noted that they're working with us, and we as NHS England, but essentially the pilot will be delivered via our network of excellence. We'll be delivering a national pilot to inform future implementation of the guidance, because we had some nice clear recommendations there in terms of the utility of the use of this test for our patients. But now we need to really think about, what does that look like when this is really kind of the first mainstreamed test at scale. We're using it in an acute setting. What do we need to have in place to support our clinicians to be able to deliver this service so our patients get the best possible care? And more information about that pilot should be out either by the end of this week or the beginning of next week. Next slide. And then, so final thought to leave you with is just also, because of all of this, as I've mentioned, there's loads of things to think about. So, but basically our vision is this, that individuals will have access to what we will call pharmacogenomic profiles. So this is all their kind of data around pharmacogenomics as part of their NHS health record to optimize the use of their medicines throughout their lifetime. That is what we are working towards. And so we are thinking about that systematic introduction of pharmacogenomics. We're seeing these increasing numbers of applications and tests, but that means basically we need to really rapidly scale up, as I mentioned before. So at the moment, we're in the process. Obviously, there's been a few changes recently. We have a new government. There's a lot of focus on the NHS 10-year plan, but we're still beavering away, looking at setting out our strategic approach to pharmacogenomic testing in the NHS, and hopefully next year we will be able to start to think about kind of coming out and having broader discussions about this, setting out the longer pathway to delivery of pharmacogenomics. What's our strategic direction, and having a bit of a wider consultation and conversation about it. Okay, and that's it. Thank you.
Great. Thank you very much, Vicky. We'll move on to Professor Adrian Lerena. Adrian is Professor of Pharmacology and Clinical Pharmacology, University of Extremadura, Spain, and has been leading work in Spain in terms of implementation of pharmacogenomics in Spain. So just a reminder to everybody, if you've got questions, please put them in the question and answer box, and I will try to go through all of those question and answers at the end of Adrian's talk. Okay, Adrian, please. Thank you.
Thank you so much, Munir, and thank you, the organizers, to give me the opportunity to share with you what we are doing in Spain. Yeah, it's okay. Okay, yeah, it's okay with the slides. Can you see it?
Yes, fine.
Okay. So this is the news that I want to share with you. Spain, just a few months ago, after a long process that we'll try to explain over this afternoon, decide to do a pharmacogenetics program for the whole population. We have something called National Portfolio, the National Health Care System, in which the minimum test need to be provided to every citizen. So it is a clear movement from quality of care to professional responsibility, because now, as you see on the right, this is the official newspaper for laws. Every citizen or legal resident in Spain, upon any prescription they need, or they can require a test, and the system need to provide that for free. So this is official announcement of that, was done in June 2023. And now in this public access database, any citizen or healthcare worker can go here to this web page, check for a drug, and a number of drugs will require a test prior to use it in the population. So just last month, a few weeks ago, the Spanish Drug Regulatory Agency make a kind of synergy strategy with that and opened a public database with all the recommendations given by the Spanish Drug Regulatory Agency for those drugs. So the situation is, here you have a roadmap, what has been going in Spain. You know, from 2010, and before I joined the Pharmacogenomics Working Party, Professor Pir Mohamed was saying before about that. And there is a lot of regulations that came into the SMPCs from the regulatory agency at the European and national level. Because this information, the Spanish Senate in 2019 decided to open a report to discuss about a report in which they recommend, very simply, to implement all the recommendations given by regulatory agencies. That's why last year, the Spanish Ministry of Health decided to develop this strategy. And just now, as I mentioned before, the Spanish Drug Regulatory Agency make all these recommendations. This is drug regulation, which I think is very important, because all of us doctors, we know that drugs need to be used according to regulations. So probably a genetic biomarker for diagnosis is something else, sometimes much more related to quality of medical care. But drug needs to be guided, all the use by a drug regulatory agency. On the left side, you have the number of times in which a genetic biomarker was included in SMPCs. Well, for those which are not related with the jargon, SMPCs, summary product characteristics, which is the general rules of for the use of a drug at the European level. On the right side, you have the recent review that we have been doing of all the drug recommendations that are in Spain. So, and we can say now that 55% of drugs in Spain have some kind of genetic information in the recommendation given by the drug regulatory agencies. Which type of information can you find there? They can be advised about drug selection, dosification, drug-drug interactions, safety, efficacy, and ethnicity is also included for certain drugs. So here you have an example in Spanish about siponimod, which is a drug used for multiple sclerosis. For those that don't know Spanish, you can see here patients with the genotype CYP2C933 they cannot use they are not allowed, to use siponimod. It's very simple. The Drug Regulatory Agency gave a very simple recommendation. Secondly, below you will see patients with a genotype in heterozygosis, with an allele, mutated allele and another not. They said the dosage should be decreases and so on. Interactions is also. So there's some information there which is extremely clear. So what is the problem with drug regulation? This one. I mean, we need urgently harmonization because, there are different stages. This in each column there. I know, I'm very much aware that you cannot see, but it's just to give an example. Red is when a drug is obligatory to do a genetic biomarker. Orange, which is recommended. Green is simply which is, informed. As you can see, each column is a different drug regulatory agency, and on the right side, you have the comparison between the Spanish drug regulatory agency, which is AEMPS, which is Agencia Española de Medicamentos y Productos Sanitarios. The first one on the top, you will see the comparison with FDA, and in green is when there is some kind of overlapping, which is 60% with FDA, 40% with EMA, and so on. It means we need international harmonization for that. So this is about drug regulation. How about clinical implementation? As I mentioned before, we have information there in the drug regulatory agency, and then the Senate met and they produce a report on genomic medicine. And this is they asked me actually as an expert what was my advice, and my advice was very simple. So we need to follow the recommendation given by our own drug regulatory agency. It means the Spanish agency at EMA, very simple. So based on that report, later on, the Ministry of Health, you see here, 2023, open up a working party in which each region in Spain, we have 17, the Ministry of Health at national level give recommendations, but the healthcare provider is given by each region, each healthcare services. So there was a meeting in which unanimously, so they decide to accept the recommendation that we gave. I was the chairman of this committee during 2022-2023, and we end up in this type of consensus. Just a panel of 12 genes must be available for all population and legal resident in Spain. It means if a British person is living in Malaga or Alicante, they like to, so they have the right to receive a pharmacogenetic evaluation with this panel of tests upon the prescription of 23 drugs. We call that primary selection, and 42 drugs, which is the secondary use of genetic information. It means if we have a drug that have a kind of guideline or recommendation, we already have the genetic analysis done, this drug, which will be included. So simple. We have a simple panel of 12 genes for 65 drugs. Of course, you can include more drugs and you can include more genes, but the most important part here was, to me, as a chairman of the committee, is inequality. We need inequity. I think we should make this panel available for every citizen in the same quality in every place of the Spain. And you can see on the right side, in Spain, there are big differences between different regions or community. Andalucía is in the southern part of Extremadura, which is there a little bit marked on, is the western part of the country, close to Portugal. We have 1 million inhabitants. And Andalucía, which is our neighbors, is 11 million inhabitants. So it's difficult to make things equal. Therefore, we choose to have a basic panel in order to cover the whole population. So this year, it was just the Ministry of Health announced that. So, and every Spanish citizen now know that if they go to the webpage of the Ministry of Health, that they have the right to apply for that. So which type of information will you find? Because we were beyond just a number of gene pair, which I think is very simplistic. If you go for clinical implementation, there are few items, and I think are very important. The first, which are the basic alleles that should be included, you know. Sometimes hospitals, primary care system of physicians, they ask for a panel for a private company, and sometimes we don't have control of, or the full control about the process, specifically if they are international companies. Therefore, a limited, clear number of alleles are defined by this the National Healthcare Portfolio Pharmacogenomics. Second, which is, I think, this is very important to me, genetic analysis for us is not enough. If you will do clinical implementation, you need to check for the drug treatment that may change the recommendation due to the presence of an inhibitor or a substrate. And even we define, you hear before we were talking about CYP2C9 and siponimod. Here we just decided to choose certain drugs, like here is the list, enoxicam, selecosib, etc., etc. It means inhibitors or substrates of CYP2C9, if they are used concomitantly or with another drug that is metabolized by CYP2C9, we change the recommendation. Therefore, it's recommended that the final report given to the patient need to include both the genetic information plus the evaluation of the drug-drug interactions. And the last item, there's another, which is the secondary use of genetic information I mentioned before. If we have some other drugs with the clear recommendation, we should include it. So this is the list of drugs that you will find in the Spanish list now. I mean, all of you know cytochrome, HLA, that Professor Pir Mohamed was saying about before, as DPYD, WGTE1A1 for the irinotecan, the very classical one. So you will find recommendation for ethnicity in some of them, interactions, you've secondary use of genetic information, diagnosis, and also indications. I mean, for instance, omeprazole. Omeprazole is there, but you can only order in when there's Helicobacter pylori treatment that doesn't work. And there are certain limitations for certain drugs, of course. And this is a general list, included the 65 drugs. I mean, you will see that there are drugs not only in oncology, they are in different other therapeutic groups like central nervous system, etc. Now we are working actually adding the somatic genes for cancer, which is not there. So finally, we have the recommendation at regulatory level. We have the political frame, the recommendation or strategy given by the National Healthcare, or the Ministry of Health, the National Healthcare Board decide to do, and the last decision was given by the Drug Regulatory Agency just in July this year, 2 months ago. This database, it was publicly available. Any person can go and check. Of course, it's in Spanish. You will find the drug. For instance, you have here active principle of abacavir, ATC code, biomarker recommended, and which are the allele, which is you need to test, and which is the phenotype or the that is connected with a recommendation, and the recommendation is there. I mean, so in that circumstances, before 2013, I went back to my hometown, which is Extremadura in the southwest, a very rural place, open space, full of nature, animals, but don't tell anybody because we have few people living there. Just 1 million people living there. In each size is more or less 300 square kilometers, a huge region which have certain I think certain characteristics which make an ideal situation for a pilot study. So we only have one electronic medical record, only one healthcare service, which is public, covering 98% of the population, and the population is very homogeneous. Ethnicity, the health status economically is very similar. So therefore, we did, because we will finalize actually next month, pilot implementation, global or universal implementation. This is how it works. Of course, you need to check for genes. We have 1,000 drugs with 600 genes in the SNPCs. Not all of them are included in the project, of course, but you have 1,800 clinical factors that may be relevant, or 1,700 drug-drug gene interactions that may affect. So we write a report considering the genetic relevance plus the drug-drug interactions and the clinical factor, and our report is going directly to the medical records to be followed by the clinicians, by the medical doctors. This is how it looks like. First, on the left, you have the simple report that we gave to patient. I think the direct-to-consumer strategy that is very popular in the States, I don't think in Europe is, we need to consider that, because I mean the implementation need to be done slowly, phase by phase. Second, in the center, you have the type of report that is included in the medical record, electronic medical record. And on the right side, you have directly the medical record. When people prescribe a drug, we'll find this report. And we have a clinical decision support tool to be used by the clinicians in order to prevent the use. Those are the four steps that we follow. First, we have a clinical evaluation or clinical pharmacology evaluation. First, we do a evaluation of each patient in order to find ADRs, adverse drug reaction. Then the patient is phenotype. In certain cases, we are doing as well TDM, I mean plasma concentrations evaluation. Then a pharmacovigilance evaluation is done in order to, of course, we use the classical pharmacovigilance approach. And the fourth step, we do this pharmacogenetic individual report, and I have been commenting before. And finally, as a part of this, we have consultation for patients that want to know more in the general framework, in fact, of clinical pharmacology therapeutic evaluation. This is a system. We have two paths. One is we call reactive or acute ADRs like TPYD, suicide, and child psychiatry. In this situation, we gave yes an answer in 48 hours. And we have a preventive with a PGX panel, including 12 genes. And the process is the same: clinical evaluation, laboratory with genome phenotyper, and the clinical decision supporting tool. And finally, a PGX individual report that signed by senior clinicians is in the medical record. And then we have a patient consultation possibility. So how many patients do we have already studying? 3 years. I mean, we started actually June 2001. Actually, was in the middle of pandemic. We have so far 6,500 patients. I mean, here is 6,000, but in fact, so far we have almost 6,500. And the pilot project is running for 200 doctors and nurses, mostly, that can also apply for the test. And this is a situation. I mean, the gene pair, I think, is a very simplistic approach for pharmacokinetic biomarkers. Of course, for hypersensitivity markers can be of use because the average number of drugs per patient is 6. But in certain cohorts, like oncology, for instance, emergencies, that can be even 9 or more drugs per patient. Therefore, drug-drug interactions, to me, is a major issue that need to be considered. And this is the distribution. To me, inequality is inequity. I think it's very important. I mean, people in every place need to feel that they are able to use this type of facility, because if not, we are giving the idea that only people that are taken care by university hospitals or well-developed rich country can afford to take this, which I think that should be available for everyone. So we have now 12 cohorts that we have been following of patients, and the primary care is very important. We have almost half of the people are coming from primary care, because at the end of the day, no matter if you prescribe or use the test in oncology in a hospital, university hospital, the patient will go to primary care, and drug interactions will play a role there. So therefore, I think the primary care physicians today, actually in Bilbao, I'm teaching for the primary care, for the Spanish Primary Care Association in Bilbao. There are 5,000 GPs here, absolutely enthusiastic about the use of the implementation of pharmacogenetics in their clinical practice. The last cohort that we started this month was the Argantonio, which is the polymedicated patients with more than 20 drugs a day, 20 SA. We are evaluating them, and pharmacovigilance. Gargories is the patients that have been in the hospital under diagnosis of an adverse drug reaction. So I will summarize the data just in this way. How many people were to the hospital or to the healthcare system to be treated of an ADR? 28%. I think this is a data we need to keep in mind. If we want to keep the healthcare or the public healthcare working in Europe, we need to decrease the harm or the ADRs that are produced by drugs. In how many cases do we suggest a change in the drug or dosage? 40%. We made the evaluation, the pharmacovigilance evaluation, that we do in 3 ways. One, which is subjective. We ask to the patient, do you have or do you remember any ADR in the past? Okay, they say what they remember. Secondly, we ask today, or which type of ADR do you think that you have? And finally, we make an objective evaluation of that we consider. Together in the parallel, we are doing some research initiative, because I think this is very important to keep in mind, which is Spain developed a strategy called IMPACT, que es la infraestructura de medicina de precisión, the precision medicine infrastructure, which is in the country. You know, we are coordinated that from Extremadura, just in order to provide the basic lab procedures like a quality proficiency test, clinical implementation guidelines, and pharmacovigilance. We started in Galicia, Castilla, Salamanca, Madrid, and Valencia. And interestingly, probably for you now, this is the case that Professor Pir Mohamed mentioned before. We are collaborating with him, and I hope that in the future we can put some light on this, you know, this metamizole scandal. This is a lot of concern by people, because some people have British living in Spain have some kind of harm by metamizole. So this project now is expanding to Catalonia and Andalusia and some other regions, which is covering in totally probably 35 million people. Because it's the concept. We are using CPIC and DPW, the Pharmacist Association from Netherlands, and the American CPIC consortium. But this information are coming from research protocols. It means every research protocol, as all of you know, is biased by their own inclusion criteria. Therefore, now we need to go into real world and the clinical conditions under polytherapy condition, and sometimes to evaluate what is the real effect of a biomarker in real world. So now we are following a cohort of patients, mostly now in cardiovascular drugs and mental health care, in order to, I've used these terms 3 and 4, just analog in some kind of analogy, like in a clinical trials. I mean, you have a drug ready, it's a phase 3, but later on you need to analyze what has been going on in real world. Therefore, we expect that in the future, maybe we will come with a new information, changing recommendation for certain biomarkers. So thank you very much, Professor Pir Mohamed and organizers, to give me the opportunity to share with you. And of course, we are open to share any information, protocol, because I think this is a very important issue, ethical and scientific for all of us. Thank you very much.
Thank you very much for that, Adrian. Vicky, do you want to switch your camera back on? So we can just get on to questions. So as I said, questions in the question answer box, please. I think I've seen some questions in the chat box. I'll go through the questions answer box first and see how many we can answer. So please put your questions in the chat, in the question answer box, rather than directly via microphone. So I think the first question maybe is, Vicky, it may be directed, well, to you as UK. Advances in initiatives such as Generation Study, Yellow Card Biobank, etc., newborn sequencing. How can the NHS help in refining personalized medicine strategies across a patient's lifetime?
Yeah, well, I mean, I think, as I mentioned in my presentation, we're really fortunate in the kind of world of genomics. We're very close in terms of the world of research and the translation into practice. So, you know, we're working very closely with the people who are doing kind of the generation study, and also the Yellow Card Biobank. I sit on the scientific advisory board. So there's always that thought process of, this is what we're finding out, and what do we need to find out in order to implement it in the NHS, and then what do we need to do. So I would say, you know, we're very linked in with initiatives like that, and it's all part of that horizon scanning and forward planning in terms of what the delivery of this may look like in the future for patients.
Great, thank you. I know, Adrian, in Spain, how much whole genome sequencing is done at the moment?
Yeah, we have this called, I call IMPACT, the National Infrastructure Strategy. So which are 3 places in Spain, actually, Barcelona, Madrid, and Galicia, that can be used by all of us. This is a strategy because there are communities like Rioja or Cantabria, which is just 500,000 people. Of course, it's impossible for region of Ceuta and Melilla, which is in Africa, to have genomic sequencing for all of us is very difficult. So now we are starting to be able to use these 3 facilities, because so far it's done on the basis of research activities or university research project. It's difficult to find except in big places like Madrid or Barcelona. So in the future, this is the idea, to have a national center of genotyping.
Okay. So in the UK, in England, there are 7 genomics laboratory hubs, and there are some others in Scotland, Wales, and Northern Ireland. So there are some centers. So one of the aspects, Vicky, is maybe you could start off, is that obviously if you're going to go to whole sort of system implementation, whole country implementation, is laboratory capacity. And I don't know whether you want to comment on that. And then Adrian, you may want to come in for Spain if you're going to implement pharmacogenetics for the whole country in Spain. What are you going to, you know, how are you going to so make sure there's laboratory capacity to do this? So Vicky first, and then Adrian.
Thank you. So yeah, I think kind of, as I touched upon, we're really thinking at what infrastructure we need. And I think it's very clear that in terms of, although it's very much still genetic testing and within the genomic medicine service, that model of delivery is quite different to what our genomic laboratory hubs do at the moment. So a lot of this testing is lower complexity. So potentially there's more room there for automation and a lot higher volume. So that is kind of where we're thinking about in terms of infrastructure, and as part of that strategic direction, thinking about what kind of setup do we need to have to deliver this much higher volume of tests. So that's kind of a big part of the strategic direction, is the actual kind of physical infrastructure we would need to deliver those tests, but still obviously intrinsically connected with the genomic medicine service, but may require kind of a delivery of unit of its that's slightly different to how the
kind of mega labs that we had during COVID for COVID testing.
Well, potentially, it's all being explored. Yeah.
Okay. And Adrian, how are you going to deliver the genetic testing for the whole population in Spain?
This is a difficult question because it's always a kind of different point of views. People working in genetics, most of them say better to go for exome or full sequencing and to use. But if you want to go just now into clinical practice, it is very difficult. I mean, it's not only a matter of analysis, it's an interpretation capability. You need bioinformatics, you need computer storage of data and so on. That's why in this committee in pharmacogenetics, I'm not talking about diagnosis, we decided to start for clinical implementation, a basic package of 12 genes. And most of the places, they build up an array that you perfectly know, around €800. You can do that and deliver, and to have PCR, real-time PCR for certain emergency cases. Yes, that was our idea in order to make, because this is a solution for a public healthcare system covering everyone in the country. The future, I don't know how the structure will develop, because in very many cases, private companies are coming to the countries and you lose control, quality control, and so on. So we decided to go very simple for everyone at first, and then we will see.
Okay, thank you. So the other aspect that everybody worries about is education training, and Nancy asks about how education is going to evolve with this, and maybe sort of Vicky, you talked about GE notes in the UK, but you maybe start again with the UK, and then Adrian, what are you doing about education training for your Spanish healthcare professionals?
Yeah, so I think in terms of kind of specific genomics education, as I said, we have national genomics education. You create a range of resources. I mentioned Genotes. We also have things like the clinical pathway initiatives, which think about various points of the pathway and what a clinician would need to know at each of those points. There's obviously a huge amount in terms of the specialist clinical genetic area, but we're also thinking a lot about what we need to support clinicians in the mainstream, and obviously pharmacogenomics is a great example of that, because essentially everyone needs to know. So if I can talk from kind of my experiences as a pharmacist and the work we've done on the pharmacy workforce strategic framework for genomics, that is set out in terms of what does everyone need to know, and that's from kind of awareness to education and training, and starts from university level. What do we need to put in the curriculum? And we've done that. We have some initial education and training standards that have been released, and then starting to think how it embeds into the training pathway of clinicians throughout their life. So it's not you have to go off and do another module. Obviously, we'll have specialists who will do that, who will do the MSc and other parts, but we need to embed that training across normal clinical training on a day-to-day basis. And I think, we're also very acutely aware, particularly while we're reaching that point of hopefully kind of universal knowledge and kind of building it into our existing systems, that as we implement individual tests, we might need to think about the specialties where it's been implemented and what those clinicians need while we're building up that wider infrastructure.
Okay. Adrian, what's happening in Spain about education training?
The situation in Spain, I will try to make a big problem short. So we have two things. One is genetic analysis, and we have a problem there because medical or clinical genetics is not a specialty in Spain, and there is a lot of debates and fights about that, because people doing that are mostly research people, because there is no healthcare qualification for this activity, and now it's a big topic of fight in Spain. So, and how about the reporting? The reporting in pharmacogenomics, I'm not talking about diagnosis, according to the Spanish portfolio, need to be done by a drug specialist, because you need to take the genetic analysis to check drug treatment and then to deliver a report, official report, like a therapeutic consultation. So my personal view is we need a drug specialist. In Spain, there are two major qualifications, which are hospital pharmacist. Primary care pharmacist is not a specialty in Spain because it's a primary sector. And it's a little bit crazy. We have bullfights, and this is a joke. We have primary care belong from private sector, but hospital pharmacy is a specialty like clinical pharmacology. So in that situation, what we are doing is the medical association, the association of National Association of Physicians, is we have a program just for people to be qualified how to use the test. It's not for research. We are very lucky, and I just acknowledge your participation. Professor Pir Mohamed is coming the 16th or 17th of December in this program, just in order to disseminate from the National Association of Physicians, because every scientific specialty is doing their own training, but it depends what is the position in this type of situation. Probably the trainings are different. In concerning medical schools, we're training that in the clinical pharmacology course. I'm including my students, and in pharmacy in grade and postgraduate is also some training. There is no a clear, and harmonized program so far. That's why I think the National Pharmacy Association and Medical Association need to be included on that training. Initiative like this today are extremely important.
Okay.
Because each specialty is biased
Yeah.
by their own professional interest. I'm nothing against that. But since it's a new space of professional growing, there are certain bias. And to avoid that, it's better to be a little more neutral. This is open my position.
Yeah. Diplomacy helps, as you said. So, yes. Okay, so the next question is really about ApoE4 for the lecanemab for FDA label. But just to put context to that, I'll answer that very quickly. So FDA, the label basically says encourages, but there's no mandate, ApoE4 testing. In the UK, the MHRA has actually licensed lecanemab with mandatory ApoE4 testing. While the European Medicines Agency has declined lecanemab. So there are various things which are happening. In the UK, although the MHRA has licensed lecanemab, it's not actually reimbursed at the moment, so NICE hasn't recommended it. So again, that's out to consultation at the moment. So I think in most cases, you do, as a doctor, when I ask for consent and so on, I'll give them the context of the test that I'm doing and any implications. And in this case, one would have to talk to the patient about ApoE4 testing and the implication for the patient and the potential family members as well. Whether that's going to have to be verbal or written will depend on guidance that's provided with the UK healthcare system. But the majority of cases, as I was saying earlier, in most cases, it is just verbal consent because there's no disease relevance. Here, ApoE4, there is some relevance, particularly for ApoE4 homozygotes, and we already do BRCA1 testing, and so we can follow the same principle as we do at the moment there. We are sort of got 8 minutes to go, and it will by the way, the webinar will end at 35 minutes past. There's a hard stop, so we'll try to get through as many as possible. So the next question, literally 2 or 3 word answers. First of all, is that when do you think pharmacogenomics will implement it along the lines you've discussed? 2 years, 3 years, or longer? So Vicky, very quickly, and then Adrian, very quickly. What do you think?
So I showed my plan, and that's what we're hoping for. I think obviously it's dependent on, we've already discussed, we need kind of that infrastructure, that investment in the infrastructure, I think, to really get it off the ground. But that's, yeah.
Okay, Adrian. When will be implemented in Spain for the whole population?
We are already available for all the population, but now how to harmonize the system.
Yeah.
How to put the information in the medical record in the same way. And this is the debate, but we make the law before to put that in practice, which is very Spanish and probably very difficult to understand for a British person. So everyone has the right, but now we are working in all the infrastructure. We will see, but it's just legal there, so every patient can apply. We will see how, but I think we have created the need, and now I think we need to develop the paths. But I'm very optimistic because we were very humble, very basic, very simple in order to make that available.
Okay. So something about private pharmacogenomic panel testing. I guess there are companies in the UK that offer that private pharmacogenetic panel testing at the moment, so people can have that done whenever they want to. They unfortunately have to pay for that. In Spain, is there private pharmacogenetic testing going on?
Yeah, absolutely. There are very many companies. It's a new sector to growing, but they are focused in certain diseases and drugs. And that's because I believe there need to be a full panel for whole population with quality control tests and reporting, because reporting must be based on the current drug treatment of a patient. But you know, when you go to a private report, they give a report for the whole life, which sometimes can create a problem because a patient change treatment, the report can change. So there are very many companies in Latin America. There are quite many offering services that by doing a genetic analysis, you will solve all problems. That sometimes is not exactly true, because to predict an ADR is extremely complex. You can help, of course, and ethically we need to do that.
Yeah,
But
and one of the other things with companies is that they always have different panels with different genes in there, and sometimes the interpretation is also different as well. If you look at different reports from different companies, and there's no harmonization, and that's an issue, and that's something that we may be able to tackle. There's some a program of work that we've applied for funding for in terms of private sector innovation. That's Nathan's question. And if they get the funding, then hopefully we'll be able to help with regard to private sector innovation as well. And that's funding to Innovate UK. We haven't heard from them yet. Jeremy's asking another question, but I'll move on to other people, first of all, just to give them a chance to ask questions as well. Then there is this thing from Daniel Murphy, Imperial College, about phenotyping for TPMT versus genotyping. So Vicky, I don't know whether you want to take that in terms of what we're doing at the moment in the UK.
I'm just reading it. Sorry. So
the French dialect.
I mean, I think that.
Yeah.
Sorry, did you want to take that, Adrian?
Yeah, go ahead.
No, go ahead. It's just
okay. Yeah, I mean, I think that's a very fair point, and it's something that's obviously considered as part of the evaluation in terms of when we are looking at using these tests in practice. So as I mentioned, we have our expert kind of evaluation process. So that's part of the consideration, because yes, something like TPMT where phenotyping is kind of established, we make that consideration kind of on, because we're thinking about the clinical pathway and where it's implemented, which is preferable. So it forms part of our assessment, yes.
Yeah, and there are some places in the world which actually carry out both phenotyping and genotyping. And phenotyping is supposed to be able to cover everything in terms of all the different polymorphisms. But if you look at the TPMT panel, 4 variants actually can test for about 95% or 92 or 94% of all the different variants in terms of mutations. I guess ideally it would be good to have both. But we need to be able to see how we move forward with that. There's a question from Alan Richardson. Immense number of polymorphisms that have been associated with drug response, making it impractical to test the validity in traditional clinical trials. How can we deal with this? Adrian, your thoughts on that?
Yeah, we are including actually, in the Spanish Clinical Research World Network. We are thinking about precision clinical trials. I think it's crucial, yes, to include pharmacogenomics during the research process in order to increase at the marketing time, the safety of the drug. We cannot go afterwards after the marketing process. I fully support, for example, bioequivalence study is unethical to do a bioequivalence study with a potential outlier due to the presence of a pool metabolizer. I think we should do pharmacogenomics for sure during the clinical research, and there is no doubt about that. We need to clear rules. As you mentioned before, this point is very important, Munir, which is the analytical control, because there are a lot of companies coming from very many places in Europe and results coming from different places in the world that some of them are trustful, some of them not.
Okay. So we are coming to the close. There's only 1 minute left, and we may just be able to answer one more very quick question. Adrian, without knowing the prescribing systems available in Spain, how do the prescribing systems across access the patient genetic test results in Spain?
This is crazy because there are 17 different prescribing systems, which is, and now we are harmonizing something. That's why, to me now, because we are studying pharmacogenetics, it's very important to put all of energy in harmonizing and preventive harmonization, because now we are connecting the medical records, and we have a national program in order to play with information in the same sense, because this is a very important issue that we want to. We have a problem with that. In fact, each region has their own system, and we are connecting in the best way that we can now.
Okay. So I'm just going to basically thank everybody for joining. We had at one stage about 140 people online, and about 300 have registered. Some people will be watching this afterwards, when they have time. Thank you very much to Adrian and Vicky for doing this. Really, really grateful for you to be able to do this. And there's lots going on, and I guess it's important that the UK and Spain learn from each other. Because we are all trying to do the same things and so on. So I think we'll capture all the questions, and we will try to answer them separately if that's okay. So the BPS team, please capture the questions and so on. We'll try to answer those. Thank you very much, everybody, for joining today, and have a good evening. Thank you.
Thank you. Thank you.
Bye-bye.
I love you. Bye-bye. Bye.